still together. So thank you for joining us. And I guess what's really exciting about tonight is that this is a demonstration of a fantastic collaborative process that's gone on. So I'm sure you all know about health pathways. And of course, in this area, it's the Sydney Health Pathways. And we've had this fabulous collaborative relationship building up some fantastic pathways with our presenter tonight. And so all of what you're being told is actually on health pathways. So we're just going to get a personal run through, which is fantastic. So I'd like to formally introduce Dr. Sai Rajendran, and he is a vascular and endovascular surgeon, and he works at both Concord Hospital and Sydney Adventist Hospital after training at UNSW and having quite an interesting tour around the world, doing all sorts of fabulous learning, including the one I was interested in, with Padua, and he was there as the pandemic was arriving. So he's probably got some great stories, but we might not have time for them. Anyway, welcome so much, Sai, and don't forget questions in the Q&A, and we'll run through those at the end rather than interrupt the presentation. Over to you, Sai. Thank you.
No problems. Thanks, Margot. I'll just start sharing the screen. Okay, I just want to make sure everyone can see and everything's okay. Are you happy, Margot?
Yes, I can see it's great. Thank you.
Perfect. Just wanted to thank yourself, thank Lydia for giving me the opportunity to do this talk. Also wanted to thank Lara, who I worked with closely in developing or working with her to help with the vascular pathways. And today's evening, as you mentioned, is really just to focus on some of the key concepts in vascular surgery that has changed or evolved with that time. And this is all documented well in the pathway. So there's just a couple of key points that I really want to for you guys to take away or take home. So I just wanted to focus on 4 key areas today: carotid disease, varicose veins, aortic aneurysms, and PVD. So some very common stuff that you do see through the rooms. Let's start with carotid disease. So firstly, carotid disease or carotid stenosis has evolved over the last 10 years or so. And in summary, or in principle, the main change that has occurred is that we really don't offer surgery to asymptomatic patients, despite the degree of stenosis. So with carotid disease, we divide patients normally into symptomatic patients. So this patient that's had a TIA or a stroke, and then you have the asymptomatic patient who's incidentally found to have carotid artery stenosis. So that's often picked up as part of surveillance or as part of someone doing a thyroid ultrasound, see some calcification in the carotid vessels, they end up getting a formal carotid duplex. Some of the cardiologists routinely do carotid surveillance if patients have coronary artery disease. A lot of the cardiac surgeons also do carotid scanning before their intervention. They pick up some disease. And so the question is, in the past, we used to treat a lot of asymptomatic patients. However, now we really don't treat many asymptomatic patients at all. So we know that the symptomatic patient does get treatment, and that's obvious. So greater than 50% ICA stenosis with contralateral localizing signs will benefit from carotid endarterectomy, okay? And the benefit is proportional to the grade of stenosis. And that's the greater the stenosis, the greater likelihood that this patient will have another event. And hence we do treatment above 50%. The other thing is that patients that have had TIA are at lower risk than patients that have had stroke. So amaurosis fugax is the is in between. So it goes TIA, amaurosis, and then stroke in terms of lowest benefit to highest benefit. There was an initial vogue of carotid artery stenting, and that was 5-10 years ago. There was a push towards minimally invasive treatment of symptomatic or asymptomatic carotid patients, but the evidence has now come up that a lot of these patients end up having stroke during the intervention because of the manipulation of wires. And now we've gone back to really reserving only stenting for patients that have had radiotherapy or scarred necks and that have had some that have contraindication for an open intervention. So let's look at the asymptomatic patients. So in the past, anyone greater than 70% who was asymptomatic would have got an endarterectomy. But with the widespread nature of statin and antiplatelet therapy, we have really reduced the stroke risk in these patients, or these patients generally don't go on to have a stroke if they are treated well with an antiplatelet and a statin. And so what this means is that the margin of benefit for these patients has really declined to the point where surgery carries very little benefit and now is not usually offered. But there is a but. So there is a small subgroup of patients who are asymptomatic that may benefit. And the factors to consider include patients with severe bilateral stenosis. By bilateral stenosis, I mean greater than 80% bilaterally. Male patients, women generally tend to have a higher surgical risk, and thereby they form into a higher category if they do have intervention as an asymptomatic, and so they don't confer much benefit when treated asymptomatically. Young patients, if they've got greater than 5-10 year survival, may have some benefit. And then you've got patients that have had cardiac or are going to have cardiac surgery, or patients with previous history of carotid related stroke or TIA on the other side. So there is only a small group of patients that would benefit from asymptomatic surgery. So what happens when you get a patient that you've had a scan, someone's come back and said, oh, they've got some stenosis, but we're not going to treat it. So do you have to surveillance this patient, or do you have to subject them to routine ultrasound every 6 months to a year? My opinion is that I don't think that these patients require routine surveillance. It would be worthwhile in a young patient who's known to have some carotid artery disease to possibly have a 5-year scan or interval 5-year scan would be reasonable, but not essential. It is important. What to take away is that if you found that this patient has got carotid artery disease, then they should be placed on best medical therapy. The other thing that they should be screened for is really coronary artery disease. And so they would have concurrent coronary artery disease, and perhaps they will have more benefit from having more investigations from a heart perspective, rather than looking at other areas of the arterial tree. So in summary, this is really a quick slide that really summarizes patients that have had stroke, yes or no. And this talks about what I've talked about. So if they've had a stroke, and if they've got greater than 50% stenosis, we know that they will benefit from carotid intervention. So if they haven't had a stroke or TIA in the last 6 months, so they're the asymptomatic patient, we go and look and see if they've got less than 80% stenosis. So if they do, then they go on best medical therapy. And like I said, it's important to then look for adjunctive coronary artery disease and seeing if they need intervention for that. But then the patient that's got the high-grade stenosis, you're going to have to really look and see if they fall into that small subgroup. So they're generally male, have got good life expectancy and potential suspicious features on imaging, then these patients may benefit from asymptomatic carotid intervention. So the next topic we'll move on to is varicose veins. And very common presentation, huge range from cosmetic to just leg pain or aching legs at the end of the day, to patients that have had ulceration, pre-ulcerative lesions, significant hemosiderin staining, stasis dermatitis, large bulbous varicosity. So a huge spectrum of patients that present to the rooms. So up to 50% of the population do have venous disease, and we often refer to the term venous hypertension. So they've got significant pressure in the venous system that is resulting in the changes that can be seen. They often have a functional problem, but then you also get the small group that's coming in for cosmetic concern. And the three common components of this venous hypertension is an inadequate calf pump. So you might see this in patients with that don't mobilize much, that have a four-wheel walker, that trottle into your rooms, that aren't really that active. So they're not using their calf pump to push the venous return back up to the heart. And it's the same thing, what I often tell my patients, when you get a long haul flight, if you're not using your calf pump, that's why you get your leg swelling. Then you've got your valvular incompetence, which is what we often deal with. So it's the venous, or it's in layman's term, the varicose veins. And then you also get the patients with venous obstruction. So these are the DVT patients that with chronic DVTs, they end up having long-term venous hypertension. And we do now start treating some of the long occlusive DVTs with thrombolysis or newer suction thrombectomy agents to prevent them from having the chronic long-term complications of venous hypertension. So the symptoms, like I said, is, you get the cosmetic patients. You do get patients coming in with superficial thrombophlebitis, secondary to the actual anatomical problem that is the varicose veins. Patients with high venous hypertension end up having some occult bleeds as well. So it often happens in the shower. So they might say they were showering and then suddenly it bled, and that's because as you know, the skin is trying to thermoregulate. It causes a shift in blood to the skin vessels, and this is often in the venous tree, and then they get a sudden occult bleed as a result of the fragile varicose veins that they have. And then you get these non-specific symptoms. So they can get fatigue, heaviness, discomfort, a lot of restless legs, pruritus from the stasis dermatitis. And it is important to really evaluate, could this patient have, even if you don't have visible varicosities, could they have some form of venous hypertension? Secondary to, is it a calf pump problem? Is it a venous valvular incompetence problem? Or have they had long-term DVTs or previous DVTs that is resulting in some of these non-specific symptoms that they're having now, despite having the DVT over 5 to 10 years ago? We do have a classification system for varicose veins, and a lot of the time you might see us write in our letters CF grade 3, 4, 5. And the main reason we do write that is that, unfortunately, in the public sector, that if you don't have veins greater than C3, that is anyone with skin changes or complications from the veins, you cannot get on the public wait list. So if it is a cosmetic concern and they have mild symptoms of just pain or some aching veins, unfortunately, the way the public sector is and the way of funding, we unfortunately can't treat these patients. I don't think this is necessarily the right thing, because I do know that a lot of these asymptomatic, these patients with minor veins do progress on. And I think they would benefit from having some treatment early, but unfortunately we can't. And the way the public sector works is they think that we could potentially keep them in compression stockings. But as you know, patients that you've recommended a compression stocking, they often come back saying it's too hot, it's hard to put on, they're not going to wear it. So I often, if you do start someone on compression stockings, start them on a lower grade. Although grade 2 is what's recommended, I think grade 1 is fine. And then although above the knee is what's recommended, I think below the knee is fine. So any form of compression is better than none. And then hopefully that reduces their progression to C2 to C3 and above. And usually the wait list, because it's a category C, is can be up to 12 months. So the first thing is if you do feel that this patient does have some venous incompetence, is to start off with a venous insufficiency scan. Sometimes it's good to also ask the patients, do they have, especially in females who perhaps would say, I've noticed my veins after pregnancy, I had severe vulval varicosities during pregnancy, I had really bad hemorrhoids during pregnancy. They may potentially have an ovarian cause for their veins and would benefit from a ovarian vein scan to look for this as the primary source rather than the source starting from the groin. It is also important to determine the arterial flow. So if you can feel pulses, that's fine. But if you can't, then it will be good to determine if they have concurrent arterial disease. And the duplex scan is to really look at both the deep system and the superficial system. And it allow us to look for, is there a obstructive problem, like I said, so is there ongoing DVTs, obstructions, or is there a valvular problem, which is the incompetence that can be seen, and then seeing what form of treatment that these patients would benefit from. So looking at the duplex ultrasound, if you notice someone that has deep venous incompetence, then as a rule of thumb, they're probably not suitable for any intervention for their superficial veins. So even if they have both deep and superficial venous incompetence, because their deep system is affected, we cannot treat their superficial system because they're relying on both systems for the drainage of the leg. The second thing is, a lot of GPs have asked me, oh, why do I repeat the ultrasound when it's done at an external imaging place? And the reason is mainly for us is to determine the anatomical characteristics that determine what form of surgical method is suitable for this patient. Sometimes with these days, we can use thermal ablation or laser therapy. And if the vein is tortuous, or if they have a pelvic source, or if they have multiple branches coming off at the junction, then they would be better off having an open ligation. And it is really a surgical reason why we often repeat the scan at our dedicated labs, just because we can have a diagrammatic representation. But I think an external scan would at least give you an idea, is the patient having a deep system problem? Is there a superficial system problem? Is there a problem with both systems? And is it an obstructive problem, or is it a incompetence problem? Because if it's an obstructive problem, you cannot treat the incompetence as well, because the venous tree is relying on the incompetent system for additional drainage of the leg. So the first line treatment, and this makes a big difference, is encouraging patients to walk, and this helps improve calf pump function. So you sometimes get these patients with multiple etiologies, so they're often on steroids or some form of rheumatological agent. They've got lower limb swelling. They potter around, but they don't mobilize much. Just simple things by getting them to walk with regular exercise to use their calf pump really helps with reducing the venous congestion and drainage, placing them on some mild compression therapy. I know I've written 25 to 35, but we could even use slightly lower than that. So grade 1 is fine, and then below the knee is also fine. And then telling them to keep their limbs elevated at rest. And then lastly, getting patients to lose weight. So if they've got significant central obesity, then not only does their treatment, despite us treating them, they do get significant recurrence quite quickly. Weight loss in itself will help reduce the venous pressure, the abdominal pressure compressing the veins, and thereby help with the drainage of the lower limbs. So when do you consider surgical assessment? And this is the duplex ultrasound I mentioned. So you often get an arterial insufficiency scan if it's inhibiting compression. Sometimes an ABI is fine in its own merit, but not all places will do an ABI. And then it's important to take an ABI with a grain of salt if the vessels are quite calcified. I'll talk about ABIs when we do the PVD section of this talk, but then the vascular surgical assessment, if they have bleeding, skin changes, edema, pain, restless legs, not manageable with compression. And then lastly, you've got your cosmetic concern patients. So there are a lot of new treatments that have emerged. And I think 10 years ago, we used to just do open surgical stripping. Now we've got a new armory of different things that we can use. Firstly, and most commonly, the gold standard is now thermal therapy with tumescent. And that's either laser or radiofrequency ablation. No difference between the two in terms of outcomes. A lot of patients come in and say, oh, I want laser, I want laser. They're both the same. I guess laser sounds more sexy and patients would like the laser treatment, but they're equally the same treatment. These patients that end up having thermal ablation, either laser or radiofrequency, require compression stockings afterwards. And the other thing is that this is only available, unfortunately, in the private sector. We don't have any funding in the local health, or in many of the hospitals that I know, you cannot do any thermal intervention. When I was in the UK, we were able to do this for all patients. However, unfortunately in Australia, there's no funding model to be able to do keyhole intervention. The problem that I raised earlier is that these patients need to wear compression. Now, you may get patients that we sometimes see, they've got neuropathy or they're old, they're elderly, they can't wear their stockings. Over the last 5 years, we've developed a new form of non-thermal, non-sclerosing, that's VenaSeal, which is a glue ablation, which I'll show you a quick cool video about next. But that is another adjunct that we have to be able to use for patients that can't have compression therapy. For patients with minor veins or spider veins, they can have sclerotherapy. And there are a lot of cosmetic places that do sclerotherapy, which I think is fine and it's great, but sometimes they often don't address the underlying problem, which is the truncal vein that's leaking, which is the long saphenous vein or the short saphenous vein that's leaking. And these patients will get some sclerotherapy, will get some cosmetic benefit early on, but then they get significant recurrence quite quickly. And it is important when doing the ultrasound to see, does this patient have truncal, by that I mean long or short saphenous vein incompetence? Because if they do need to address that, and there's no point just doing sclerotherapy to this. The other thing with sclerotherapy is that with younger patients, I often recommend them seeing a cosmetic dermatologist, because rather than us injecting these spider veins, they often get a better treatment with topical laser, which is now done through some of the cosmetic dermatology practices will do that. And it avoids some of the staining problems that we see with sclerotherapy injections. So they've got young patient topical veins that are just spider and they want something done for cosmetic reasons. They're better off seeing a cosmetic dermatologist to have that addressed. And lastly, open stripping still done, and sometimes these patients, this stripping is the best option because they may have had some clots in the superficial veins before, and we can't pass any of the probes or laser probes up, or the veins are so tortuous, or we need to address a feeding source that's coming very close to the junction that won't be addressed with a thermal intervention. So this is just a quick video. I'm not endorsed by Medtronic or anything, but I just wanted to show. I'll kind of push this forward. It just shows you. This is the new glue system where we place the catheter through, and then we use an ultrasound probe to check the vein and then start delivering this glue device, which is fantastic. So it avoids the use of tumescent, it avoids the risk of thermal burns that patients can have if the vein is too close to the skin surface, and we just compress the veins, and good for patients that end up having that cannot tolerate compression stockings as well. So it avoids the use of compression stockings. So newer devices that are getting developed, which is great for patients with as technology advances. minimal scarring, and they end up just with a keyhole treatment. Okay, so let's talk about abdominal aortic aneurysms, a common topic that's well known to vascular surgeons. It's something that we're always linked hand in hand with, and there has been significant evolution over the last 20 to 30 years with abdominal aortic surgery, as you know. So abdominal aortic aneurysm is a common problem, and the main problem is the risk of rupture. It requires careful attention, and important is to understand the risk factors, and also to understand the importance of screening and at what size we start worrying and consider treatment. So the risk factors of aortic aneurysm disease is mainly smoking in the Australian population. You do have also genetic predisposition as well. And so if patients are smoking, it's important, and they do have a small aneurysm that's picked up, it's important to really push them for smoking cessation, not only just for the aneurysm itself, but also for their peripheral vascular disease and reducing peripheral and coronary artery disease as well. As you know, traditional treatment is offered at a diameter of 55 millimeters. Patients with AAA that's larger than 50 millimeters should be generally referred to a vascular surgeon. And once it's reached about 55, we often plan for surgery. Some things to note that some of us aren't aware is that if a patient has an aneurysm that's greater than 55 millimeters, they cannot drive, okay? And anything larger than 6 should be referred urgently, often either to direct contact with a vascular surgeon or within a week or two to the vascular surgeon's rooms. The other things to be mindful of if a patient is symptomatic, so if they've got a tender aneurysm, then I think they should be referred urgently to the emergency department. And then obviously a ruptured aneurysm is referred urgently to the emergency department as well. Sometimes, so what happens when you get the aneurysm that's less than 55 millimeters or less than 5 centimeters? Sorry. Sometimes the small aneurysm can be painful and can cause us to intervene earlier. We don't really understand the importance of pain, but we know that pain is associated with a higher risk of rupture, and often we treat those patients quite urgently. There is also a tendency to offer surgery to women at a smaller size, and that's because women are generally smaller built than men. And a lot of the old UK studies were based on men, and a large proportion of the patients enrolled in the studies were men, and that's why they used the cutoff of 55. But in females, I generally tend, once the aneurysm reaches above 5, often they get repaired. And then patients with a strong family history of rupture, and especially documented rupture at a small size, should possibly considered for early intervention as well. So if they've had a family member that's ruptured at 4.5 centimeters, then once the aneurysm reaches that threshold, they should be considered for treatment. So when you get a patient that comes in and that's got an incidental finding of a 4.5 centimeter aneurysm, the things to talk to the patient about is, do they have any first degree relatives greater than the age of 50? All these patients should be screened for aneurysm disease. So if they've got siblings, or if they've got children above the age of 50, they should all just get a simple duplex ultrasound of the abdominal aorta to see if they've got aneurysm disease. Secondly, patients with abdominal aortic aneurysms often have concurrent aneurysms as well. So they could have a popliteal aneurysm, or they could have also a thoracic aneurysm as well. Popliteal aneurysms are often treated when they are at a threshold of 2 centimeters, or if they've got loss of distal pulses. So that means that popliteal aneurysms have formed clot and they've sent off distal emboli to the distal vessels, and that's why you can't feel the distal pulses, and they are considered a symptomatic aneurysm and thereby often treated as well. So first degree relatives and siblings, and then also looking for concurrent aneurysms if you do get a patient with an incidental aneurysm. So these patients, you can screen them yourself. Sometimes we get referred these patients and we place them on our own surveillance program. So they just come in for a routine ultrasound and then get screened. But if you want to screen them yourself, that's perfectly fine. There are a couple of guidelines. Here in Australia, we generally use the European guidelines just because we've got easier access to ultrasound. So aneurysms between 3 and 4 centimeters often require another surveillance scan in 24 months. Once they reach 4 to 4.5, you do them every year, 4.5 to 5, 6 centimeters. And then by this stage, I think you should be considering referring this patient on, provided you have excluded aneurysms elsewhere and also screened their family members as well. So theaters in the past, aneurysm surgery was a big spectacle. We used to do big open operations. You know, from the medical student to everyone would be there for an open aneurysm repair. And we didn't call them theaters for no reason. So we wanted to have a big audience, everyone watching the surgeon doing their great thing. But we have really switched our paradigm of treatment. We have evolved technologically, and we now treat a lot of our aneurysms keyhole in a hybrid theatre in a setting like this, where everything is done to a minimally invasive approach through an access to the groin or the arm. But before we talk about how to treat these aneurysms, I think we really need to give respect to some of the surgeons that have really pioneered this. And the main reason for me showing this slide is that these guys are all Australian surgeons who are really at the forefront of doing the first keyhole surgeries in the world in probably 1995 to 2000. These guys were doing the first in man stuff. And the two gentlemen on the far ends of this photo, John Anderson, Martin Lawrence Brown, were from Perth. And the guys in the middle that I put in were actual local health surgeons. So these guys were the RPA surgeons. So the late Jeff White and also the late James May, which some of you guys may have referred to in the past. I have fortunately had the opportunity to work with Jim May, doing my research and doing a master's with him, but a very humble man who was really, you couldn't tell that he made a huge difference in vascular surgery, such a gentleman. So, but these guys were, interestingly enough, were operating at 2 a.m. in the morning, purely to be able to live stream a lot of the cases to the US, and also the operations at the time were taking 4 to 5 hours to do a simple aneurysm repair keyhole, but we now are able to do them in 45 minutes to an hour with good surgical planning. But it is important that we recognize these Australian guys that, and also local guys that have made a huge difference to what we are able to do today. So this is just a small snippet of kind of how we treat aneurysms. Again, I'm not endorsed by Cook. It's just a good video that summarizes kind of what we do. You can see the big aneurysm in the middle here.
And advance the graft. The flexor sheath and nitinol inner cannula help track through difficult anatomies. Next, when the graft's in position, pull back the sheath. Then, remove the wire. The capless design leaves nothing to retrieve. Active fixation creates fewer chances for stent migration. Zenith LP's multiple sizes and configurations mean one off-the-shelf modular solution for simple and complex anatomies. Xenotherapy, precision, simplified.
So essentially, we place a stent graft these days to provide a seal of the aneurysm. So it's like an inside tube open aneurysm repair with a stent graft. And these patients, you may wonder why we continually see them after the operation. And that's because although endovascular aortic aneurysm repair has a lower morbidity, it has a high rate of recurrence. And that is because, as you can see, we're relying on actual wall apposition of the stent graft at the top end and at the bottom end to be able to exclude out the aneurysm. Unfortunately, aneurysm disease is a progressive condition. And what happens is this aneurysm, or the wall within where we have a seal at the top, could get bigger or could open up, and hence we start getting leaks. And we often coin that term an endo leak. And these patients need to be surveillanced every 6 months to a year to make sure that they're not developing any leaks. Because if they do develop a leak, then they can develop a one-way pressure system with nowhere for the blood to go out. And hence the aneurysm that we treated before is now no longer excluded. And then you've got a pressurized sac that could rupture quite quickly. And so also we're relying on these modular pieces to it's really just for opposing graft with graft, and they could dislodge, they could kink, and then we've lost a seal again. So that's why we surveillance a lot of these patients. So although the keyhole approach is lower morbidity, lower mortality, it does mean that these patients are subjected to long-term surveillance. It also means that these patients are subjected to possible reintervention rates as well, to high reintervention rates as well. So it is important that these patients continue with the surveillance program, or encouraged to continually follow up. In a young patient, we still may consider, or will consider, an open repair because it avoids the need for long-term follow-up, and also the country patient. So this patient that is not going to follow up because of location of where they live, or these patients with poor compliance, we may also consider doing a open repair in the first instance, as we probably do them a disservice by doing an endo repair and them not following up and then having a sudden rupture due to poor follow-up. So lastly, just to bring the evening to a close, we'll look at peripheral vascular disease or peripheral artery disease, which causes restricted blood flow secondary to atherosclerotic plaque. We all know the disease process, the same disease process that's happening in your coronary vessels, and it's the same pathology that's happening in your peripheral vessels as your coronaries. And we often have three main criteria, three main classification of PVD. So you've got the claudicant, you've got critical limb ischemia, and then you've got the asymptomatic patients. And I often really compare this to the cardiology setting to patients. So the claudicant is your patient that's got stable angina. So they get some chest pain when they walk a certain distance. The same thing, they're getting a lack of blood supply that's not able to meet the myocardial oxygen demand of the calf muscle when they mobilize and since they get pain. So this is your stable angina patient that when it's the same process that's going on. Then you've got your critical limb ischemia patients. So these are the patients that are having acute, that are having a lack of oxygen supply even at rest. So they often have rest pain or tissue loss, and this is easily comparable to the patient that's having the acute, that's having the non-STEMI, or the patient that's having unstable angina, or the patient that's having an acute MI. So that's the thing that needs prompt assessment and treatment. And then lastly, you've got that small subgroup of asymptomatic patient who's got peripheral arterial disease, but don't really have symptoms. So this has been picked up because they've got some calcification that's been noted on a CT scan, or they need some compression, is someone's done an ABI and they've got no real symptoms, but they've got some arterial disease. So let's start off with the claudicant. And when the patient comes in, they say, I've got some leg pain when I walk. The first thing is to really counsel them about best medical therapy. So making sure that they're on a single antiplatelet, aspirin is fine, and also a statin, encouraging them to stop smoking, and then really get them to mobilize much. And that's to allow the body to form collateral circulation. Now, there is, then these patients do still benefit from some form of intervention, especially when they have lifestyle limiting claudication. And the important things that we consider when intervening on these patients is, can we potentially make this worse? And what is the degree of disability that these patients have? If they're saying they're able to walk 2 kilometers and get leg pain after that, then we wouldn't consider treating these patients. But if they say they walk 100 meters, get leg pain, or they can't function at work, or they can't do what they normally do, then these patients would consider a form of intervention, provided that the intervention is not aggressive, especially nowadays when we can do keyhole surgery. It's easy for us to put angioplasty or stent lesions in these patients. But if they require a bypass, then we probably would wait till they actually develop critical limb ischemia. And by critical limb ischemia, I mean these patients have rest pain, non-healing ulcers, or gangrene. And these patients need prompt assessment, because if they are delayed, they could potentially end up having limb loss. And essentially what critical limb ischemia is, at rest, the body is unable to provide enough oxygenation or nutrition to the muscle. And this is why these patients are getting pain or ulceration, and they need urgent revascularization before things get worse and they suddenly develop limb loss. Some people get confused between critical limb ischemia and acute leg ischemia. Acute leg ischemia is a patient that's normal and that's suddenly develops severe leg pain that's occurred all out of the blue. Whereas a critical limb ischemia patient is the one that's had pain in their legs for years and years, and that have suddenly developed worse. So they often start with claudication that then progresses on to rest pain, because they're continuing to smoke, because they're continuing not to be compliant with best medical therapy, and so forth. And they're not controlling their sugars or their diabetes well. Acute leg ischemia needs prompt evaluation as well, and that needs urgent referral to the emergency department. Often it's as a result of an acute embolus that's coming from a heart. So this patient's in AF, hasn't been anticoagulated, suddenly developed a embolic event to the leg. And this is important to differentiate this from critical limb ischemia. First line assessment with all patients is clinical examination, checking their pulses, seeing if they have sensory changes in a diabetic patient. We can often do an ABI. An ABI less than 0.8 is considered abnormal, and it is important to be wary of the diabetic patient. So a lot of diabetic disease happens in the tibial vessels. These patients end up getting very calcified vessels. And what an ABI is, similar to, so as you take a blood pressure, it's about compressing the vessel and seeing whether the blood flow returns at a significant pressure. Because the vessel is so calcified, it takes a higher pressure for the vessel to occlude, and it gives a false reading that this patient's ABI is normal. And so with a diabetic patient, you've got to take the ABI with a grain of salt. Sometimes toe pressures are done instead, because in diabetic patients, the toe vessels are often spared. But I would consider probably doing a duplex in a diabetic patient to really know if they've got tibial disease or not. In a patient with some symptoms, a duplex to either rule out vascular disease or confirm vascular disease is justified. And one of the important challenges is to really evaluate the importance of minor changes on a duplex in the face of other pathologies. So like I said, in an asymptomatic patient, you can have some minor disease And you don't necessarily need to treat this patient. It's really to see, does this patient really has symptoms? And it is that patient that needs to be often referred on. So often claudicants, tissue loss, critical ischemia. Whereas if they have disease and they don't have symptoms, the best thing is to, that they've got disease, is to really make sure that they don't have coronary disease, and then putting them on best medical therapy and then controlling their other risk factors. And some of the confounders that we face, and often you will face as well, is the patient that comes in, "Oh, doc, I've got cramping at night. I've got pain in my legs at night." And it's really hard often to really nut out, does this patient really have peripheral artery disease, or does this patient have some cramps secondary to low magnesium? Do they get benefit from having some quinine to help with their cramps? And often a simple duplex will help. If they do have element of arterial disease, then these patients may benefit from intervention. And it is important to nut out, do they have claudication symptoms? Do they have, why is their pain only at night? But then you also get the patient that's severely ischemic, who relies on gravity to help perfuse their legs. So when they're standing up, gravity helps increase the blood flow supply, so helps with the blood flow to the legs. But when they're lying down, they've got their legs elevated against gravity, and then they get pain in their legs. The other thing is patients with back pain, often confounder as well, often concurrent spinal pathology. They get pain in their legs when they walk. Is this arterial? Is this neurogenic? And some of the ways that we can help differentiate is, does this patient, the type of pain that they often say is kind of a sharp shooting pain, starting from the back all the way down, often, as you know, referred to as more sciatica. They often also get pain when they come up a hill, purely because of the position of their joint. And then they often have a history of osteoarthritis or back issues from the past. And some of these patients end up having concurrent pathologies, and it's often really difficult to nut out whether it's coming from the back or is it coming from arterial disease. And what I find is that these patients, if they require a back operation, it's quite an extensive process, and often it's good for them to just have the arterial disease treated as a way of elimination. And if they've got ongoing issues, then they have their spinal pathology sorted out, unless they have obvious thecal compression seen on MRI or CT scan. Then you get the patients with lower limb swelling that come on with leg pain. It's not really arterial in nature. And these patients often, as I mentioned earlier, it's more of a venous hypertension or swelling, often seen at the end of the day after a long day standing up, and they say the pain gets better when their legs are actually elevated. So these patients would benefit more from compression therapy and a bit of education about how to reduce their lower limb swelling. So quick slide, sorry, video showing again keyhole treatment that we do. These days we often pass wires through lesions. We used to use bypasses in the past to treat lesions such as this. These days we can do simple balloon angioplasty. Patients go home the same day or the next day. And then we, once we balloon, we can consider putting a stent in as a scaffold. And you can see here, we're not really removing the disease. We're really just pushing it out to the surface and trying to open a luminal area for blood to flow. And then these patients need surveillance because they sometimes get restenosis or narrowing following treatment. Okay, so I think I'll end it there. Just a couple of things I just wanted to inform guys that are in the local area. We do have a public clinic that's set up at Concord Hospital. The contact details are here. Some patients obviously financially find it hard to see someone privately. I run my clinic on a Monday morning every week, a half day, and they can be addressed to this number and fax. My private room's number is here, and take a moment. Please feel free to put that number, put my direct mobile into your phones. I'm more than happy to take phone calls. If I'm scrubbed in, to leave your name, I will get back to you. And even if it's a little thing, like early on, I was getting a lot of phone calls just about really finding about the COVID vaccine and the thrombus risk 3 months ago. Should these patients have the vaccine? And, at the time we knew the answer. I spoke to a couple of immunologists, and the actual cause of clotting secondary to the vaccine was more of an immunological process rather than the atherosclerotic disease process or the hypercoagulable process that patients that get DVT and things like that. So they were fine of getting the vaccine. And so even little things like that, just to answer a question, they don't have to be a referral. It's just if you find something and you're not sure and you just want to, just check out and do the right thing by the patient so that they can get an answer and you can, without them having to see someone. I'm more than happy to take questions and answers. Or if you've got a patient that you think needs an urgent review, happy to be called to facilitate that to happen within the next day or so. With that, I'll leave this up there, and then I'll probably give it back to you, Margot, if you've got anything to add about pathways, and take on any questions as well.
Thank you, Si. That was really, really interesting. And it is, I think it's so interesting how much has changed, certainly in my lifetime. Certainly all the aortic aneurysms were done open. And yes, I do remember them being a very long, and tiring session. So if we just put a couple of questions up, I think
Sure.
Marie was asking, I think it's a really critical one, isn't it, about how do we actually monitor triple A's?
Yeah.
And how do you follow up the size? You're saying, what sort of screenings, an ultrasound, a CTA?
Sorry to interrupt. Yeah.
No,
So an ultrasound, sorry, I should have mentioned that. Yeah, the ultrasound is more than enough to start with. Once they reach about 4.5 to 5, then you're probably looking at considering a CT angiogram. The ultrasound can also be done for the popliteal vessels as well as part of screening as well. So the ultrasound is non-invasive. It's often cheap or bulk billed, and they can get it done anywhere. Sometimes I have had this before where they picked up an aneurysm, or they thought they picked up an aneurysm from an ultrasound, but purely because sonography is a user dependent. Sometimes they've looked at the spine and thought that was the aneurysm, but most of the time the ultrasound is more than fine for surveillance. And it is important to go to the same place. So often we try and keep the same sonographer, because it means that the aneurysm is being followed up with the same kind of technique that they're using, and they're measuring the same way, so they can check the aneurysm, provided that the aneurysm is not causing any complications, so any distal embolization, then it's fine. If the aneurysm suddenly grows rapidly, so we often say greater than 0.5 in 6 months or greater than 1 centimeter in a year, then that would probably warrant a CT angiogram to see what's going on and why there's a sudden growth.
I think that aortic aneurysms seem to be the area we've got most questions about. So the next
Sure.
question is also about aortic aneurysms. Should we be screening for these? And if so, who do we screen?
Yeah, so the UK has, they've got a big screening program that they've established. So what they do is screen everyone above the age of 50 or 55. They screen all males and they screen all smokers. So greater than 55 male smoker often gets a abdominal aortic aneurysm screen. However, in Australia, we don't have an official screening program, but I would see no issue or in screening these patients. And I think that's the small subgroup that they've shown the greatest benefit in screening and early treatment. So if you've got a gentleman that's, you know, above the age of 50 who is a significant smoker, these patients should be screened. Anyone else, there is very little benefit in screening as per the UK data.
Thank you. And then there was a interesting question about, is there any association between aortic aneurysms and cranial aneurysms?
There isn't, and there's a lot of people that have asked this in the past as well. There isn't really. It's kind of a separate disease process. Often the cranial aneurysms are more of a genetic predisposition. So if they've got a family history of Barry aneurysms or have previous aneurysms in the brain, then they often will have a tendency to form aneurysms. But if they've got abdominal aneurysm, it's a separate disease process where it's more of a atherosclerotic or a weakness in the wall secondary to degeneration, as opposed to more of a genetic condition that's causing the vessel to weaken. So there's no real association between those two.
Fantastic. We've got a few seconds left. Anyone else wants to put a question up, but I think I'd agree with Elizabeth's put up the comment. Thank you so much. And it was brilliant and great to hear about something other than COVID. So I think probably all of us in the coalface today have been spent the entire day discussing, well, the COVID. And I think for me, it was the timing of COVID and discussions about when you should have your next one, which was then followed by an inability to actually access your anything earlier anyway. So if any other questions, pop them up. But in the meantime, I'll just really quickly show us the health pathways, because as I said, this has been such a really valuable collaborative process. And I can see, Lara, you are online. You can pop in and actually tell us, if you like, what how that process went. So of course, this is in our area, it's the Sydney Health Pathways, or Health Pathways Sydney. There are obviously other health pathways around. Oh, Lara's there, great. There are other health pathways around, and if your area, then you're always welcome to use ours. I'm not sure. I don't think Southeast Sydney have actually managed to do their vascular health pathways. So we're always happy to share, or there will be in one in your area. And of course, our username is connected and our password is healthcare. So any clinician can certainly welcome to that. That's our homepage. If you look down in our surgical section, we'll see our vascular surgery. So all of the things that we've spoken about today actually have all of the information you need. So there's the aortic aneurysm. Lara, did you want to pop in and speak at all about the pathways that you collaborated with Sai?
I'm just trying to find a quiet spot. Well, I think they speak for themselves, really. They're easy to follow, and Sai was a really great SME to work with.
That's a subject matter expert in health pathways speak, isn't it? So there's our carotid artery stenosis one. There is our peripheral vascular disease, lymphedema, which we didn't get time to cover today, but if we'd had a longer session, so that's a lymphedema, varicose veins and chronic venous insufficiency. This you can see is a yellow pathway, which means that it's not been localized, but it's almost localized. So I'm told that's almost ready to go. So that will give us some more information about compression therapy. And then, of course, the really important one here, which is the vascular surgery request. So we've got our urgent vascular assessments, our vascular surgery assessments, and vascular surgery advice. So that's pretty much the pathways. And I think I'll stop sharing now because I think I've got one more question jumped in. Let's have a quick look. It's again about aortic aneurysm. We maybe need to spend more time on those ones. Okay, so once we find AAA, do we do an autogram or for all people with thoracic aneurysms? Also, I think means to detect any thoracic aneurysm. So, why do we progress? You said they might have a thoracic aneurysm. So how would we diagnose that?
Yeah, so with that, you don't even need to do a contrast scan. You can do a non-contrast CT chest. A lot of these patients would have had a CT for something or another. It may be good to look back and see if that's been reported. But you're right, it'll be good to check if they do have aneurysms in the chest. But it really depends on the size of the aneurysm that you detect. So if they've detected a very small aneurysm, less than 3 or about 3 centimeters, then I wouldn't rush in to do that. But if you've suddenly detected an aneurysm that's 4.5 centimeters, again, yes, it'd be good to just see if they've had a previous CT, has that been documented? If not, then for them to just get a non-contrast CT chest, and that would give us an idea, does this patient have thoracic aneurysm? If they do, then you can then follow them up with a proper CT contrast based on the size.
Fantastic. That has been so useful, Zai. And unfortunately, 8 o'clock has come around in an awful screaming hurry. So we're actually at the end of the evening. The last question was because I speak too quickly. And that is that the username for Health Pathways or Health Pathways Sydney is connected. And the password is healthcare. So if you need that again, just contact you. There's actually a spot on the homepage that you can actually ask us for the password as well. So I'm sorry I speak so quickly. So thank you so much for coming along, and Sai, thank you very much. That's been really, really helpful. And again, thank you for your work with the Health Pathways team. Thank you.